Hi, everyone. You're listening to Let's Connect. This is LT, and I'm going to be talking about chronic pain and mental health. So, this is the third episode. So, if you haven't listened or watched the previous episodes, do so. The episodes are available on the Instagram page, as well as YouTube, and all major podcast platforms, right? If you don't know where to go to, like find a link to watch the videos, go to letsconnect.com. Scroll through the page over at the podcast episodes. It has a list of all the podcast episodes that I've recorded so far, and you're going to find chronic pain and mental health. And before we get started, I want to make reference to the fact that I'm not an expert in chronic pain. I do like the topic, and I make a commitment to learn a lot about it and to educate myself on the matter, and to also, help inform other people about this topic, because I think a lot of people are experiencing chronic pain. And I think it's important for mental health professionals to know about chronic pain, the theories behind it, and also some of the factors to consider when treating someone with chronic pain. So let's talk today more about some of the factors and like put it in perspective, put it all together, and in terms of how that it can influence our treatment. All right, because so the first episode I talked about theory of pain, like the Gates theory. I talked about the biopsychosocial model, the cycle of pain. And then in the second episode, I talked about the different factors associated with chronic pain, but not all of them, okay? There's a lot more to be discussed, and I encourage you to go to research it to learn more about them as well, or send me an email at discussion@letsconnect.com saying, hey, LT, can you talk about X, Y, and Z in chronic pain? And I'll do some of the research myself and try to compile information and bring an episode for you. Sounds good? Okay, so let's get started. So trying to summarize here some of the possible barriers or factors to consider. So meaning the factors that I talked about in the second episode. So they were individual and cultural factors, right? Thinking about how culture influences the way that we perceive pain, know about pain, and what we do about pain. Social support, how that can be influencing the maintenance of pain, and also contributed to the improvement of one's pain experience. Think back about the cycle of pain. Remember that as part of the cycle of pain, the social support is a part of it. So if we're not addressing it, it's just going to maintain the cycle of pain. And thinking about how that can influence one's perception of like a credibility, loss of credibility. If they can perceive that they can continue to rely on others for support, if they can just be part of social activities or not, because of their pain experience, it can influence their behaviors. It can influence the way they feel about themselves, they can feel about pain, and their thoughts as well. I also talked about the presence of substance use and substance use disorders, and how that can also how that is highly comorbid with chronic pain. And there's a lot of data out there to corroborate that, and how important it is for mental health professionals to keep that in mind, when you're working with someone who has a history of substance use disorder, or who is uses substance uses and possibly as a coping mechanism, then to also keep in mind that this person might be experiencing pain now, or might be reporting chronic pain in the future. Because again, it's unclear about what comes first, but it's likely that someone who is endorsing chronic pain, they might rely on substance use for coping with their pain, or vice versa. If they are substance users, or they have a substance use disorder, they're likely to be experiencing pain in the future. I also talked about how highly comorbid chronic pain is with some mental and as well as physical health conditions. So think about depression, anxiety, right? Also trauma-related symptoms. I talked about insomnia, obesity. I talked about diabetes, some cardiovascular, some lung problems. They're highly comorbid with chronic pain. So paying attention to that possibility, assessing for that possibility or the presence, stay, to have access to the medical records or talk to the primary care physicians, learn about the presence of psychiatric and medical conditions, right? And see if there's an association with their chronic pain experience now or in the future, and educating the patient on that comorbidity. Assessing for patients' beliefs and past pain experiences, how it is that they treated it, how it is that they coped with, what it is that they experience in terms of social support, or the experience that they had with the treatment team, and how that might influence the current experience or future, how it's going to influence the current treatment that you're providing them. And I talked about the presence or the use of pain measurement, and how some patients perceive that the measures are not enough for assessing for picking up on their pain experience, and how it can be difficult to rely on them to have a sense of what it is going on of that individual in front of you. And so with that in mind, there's been discussion on what it is that mental health professions can do or should do. So one is to rely on multidisciplinary treatment approach. So working with different professionals. I don't know if there's possibility to have a multidisciplinary and interdisciplinary team, but if not, then also to keep in mind that it might be important to collaborate, to talk to other professionals that are involved in the care of that patient. So that means getting permission to be able to talk to those other professionals, or placing referrals as well. And also it's important to rely on the biopsychosocial model. And that helps us look at the different factors that might be influencing the development and maintenance of chronic pain. Right. So when we're doing an assessment, so keeping that model in mind to help us conceptualize. And considering aspects for physical and medical, the psychiatric comorbidities, like I said, self-efficacy, Alzheimer's, pain catastrophizing. So there are scales that you can use for each one of them. And also scales to help assess for the presence of psychiatric symptoms, right, of depression, anxiety, and so on and so forth. But see how we're adding measures in addition to the connection that you establish with the person, like via verbal communication. Just keep in mind that it can be very difficult for the patient with chronic pain to sit and complete all those measures in one sitting. It can influence their pain. It can increase their pain levels at that moment. Some say it. Or maybe it's important to offer them, to pace themselves. You don't have to complete all of this in one sitting, do it one today, one tomorrow, and so on and so forth, so that they are not feeling overwhelmed by that given experience. Also keep in mind that it might be difficult for them to describe their pain verbally, as well as in written format. And so it might be relevant to use the answers that they provide in a self-report measure and use that as a way to communicate with them, to extrapolate from that verbal measure and talk to them more in depth about what it is that they responded. Talk about the use of medication, also isolation. So basically assess for coping styles. And consider the cycle of pain. So where they are, if they're engaged in that cycle of pain, if they've made attempts to break that cycle, and what worked to what didn't work. So there's a paper by Fink, F-I-N-K, and it was published in 2000. So I know it's been a few years, but I think it's a very good read. This author proposes that to use like the verbal and self-report, like I mentioned, ask open-ended questions, like tell me about your pain, what makes your pain better, what happens when you're in pain, and the use of self-report. But there is something that this author proposed. It's called, at least it's listed over there. I don't know if the author was the one who proposed it or not. But the approach is WILDA, so WILDA approach. So words to describe pain, intensity, location, duration, aggravating or alleviating factors. So assessing for getting words to describe the pain, also assessing for how intense the pain is, where in their body they're experiencing pain, how long they've been experiencing pain, and what makes their pain experience worse or better. Also use measures to assess for substance use risk, like the opioid risk tool. But think back about my comment on, the use of measures and how that can actually be difficult for them to to do it all in one sitting. There's a review by, I think the pronunciation is Hawker and colleagues. It was published in 2011, and it basically compiled and it looked at the different measures available for assessing pain and talked about the strengths and limitations. So when in doubt, go back to the research, right? Someone has looked at, might have already answered the question that you have and provided additional information to guide your treatment. And there's one more thing here that I want to say. So consider the education, provide education on pain and the comorbidities and whatnot, what treatment might entail, invite them to be proactive in the treatment, collaborate with them, discuss coping skills, validation of one's experience, and providing empathy. They're key factors here in providing treatment for sure. Be sensitive to cultural background and aging-related factors. And consider there's another acronym that I'm going to throw it out there for you all. So I think it says SWEM, so SWEM, socialize, work, exercise, and meditate more. So improving one's experience or one quality of life by addressing, social support and having them socialize, increase socialization, also addressing work, because remember, pain is associated with disability rate, and remember that pain is also associated with reduction in physical exercise or activities. Then so we wanted to address exercise and also meditation, which has shown to help alleviate the pain experience as well. So I know in previous episodes I've talked about some different treatment approaches that have shown to be effective in the treatment of individuals with chronic pain. And those are CBT, so cognitive behavioral therapy for chronic pain. You can find the protocols, they're available. You get training on that and use them. You can also use ACT-CP, so acceptance commitment therapy for chronic pain. You can rely on motivational interviewing. There's also something called IMPAT, I think, or IMPAT. So it's improving pain during addiction treatment. So think about the comorbidity between chronic pain and substance use disorder, and how sometimes it's important to address those two conditions together rather than separating them, because they're coming together. And sometimes it's important to tailor, to individualize the treatment, because maybe the protocol might not be sufficient, but so far, overall research does say that they're effective. So learn about them, be familiar with them, and so that you can provide the best care to the individuals coming in to your office, right? There's one more thing that I want to share with you. I came across this paper, so it's Pepin and colleagues. The paper was published in 2015. It talks about the complexity model, and I don't know if you've heard of it. So I don't think mental health professionals use it. I'm wondering if it can be used by mental health professionals. If you know about that, if you have an answer to that, let me know. Send an email to discussion@letspsyconnect.com. I would love to hear about it. So basically, assesses and accounts for different variables, such as like risk for medication abuse and addiction, number of surgeries, psychiatric and medical comorbidities, one's physical conditions, types of goals one has, realistic versus unrealistic, employment and educational history, social support, medication history and current use, one history in the environment, head trauma, the presence of head trauma, no injuries, injury or two or more injuries. So I know it sounds similar to what it is that we're supposed to assess and account for when you're using the biopsychosocial model. But then this model here, basically, it ranks the different factors, it rates them, it gives numbers, and then you have a level of complexity of that case, and it helps you then make decisions regarding treatment. So just food for thought, I guess. And like I said, if you have heard about it, if you have more information about it, I'd love to learn more. Maybe it's something that you can share with me. And because the idea is that by understanding how complex a case is, it can help the professional, right, and the individual with chronic pain determine a treatment plan that addresses the different factors affecting the complexity of one's pain experience. So I hope you have enjoyed the episodes on chronic pain and mental health. If you haven't listened to the previous episodes, please listen or watch them. This episode is also going to be available on all major podcast platforms, but also on YouTube and Instagram. My handle is Let's Connect. And if you want to go to my website, it's www.letspsyconnect.com. And remember, let's Connect.